the leadership that is required to be able to make a difference in this sector. And I think, especially for patients, we always have to remember that at the end of any decisions we make, whether you're a clinician, whether you're a healthcare financer, whether you're somebody who is making other policy decisions like those of us who are sitting on boards of institutions that make a difference, we always have to remember that at the end of that decision, there's a patient, there's a life, there's a family whom we impact. And if we always have that in mind, I think it'll be a moral compass in terms of helping us make the right decisions. So that is one thing we also always need to bear in mind. And those who are patient advocates, this is the only time when noise is a good thing. Any time when we're advocating for patient care, for me that is going to be a joyful noise. So we must continue to advocate for our patients. And there are a lot of things that policymakers might not, some unintended consequences of decisions that people might not realize. And even in our system, as things become more efficient, for example, when you start providing treatment and it's being financed, one of the things I'm very passionate about is let us not make the cure for the disease more painful than the endurance of the same. There are times when we must admit patients are put on treatments that are inappropriate. So there are times when you've got patients who have reached the end of their life, and there is a time when we have to admit that the end of life has come, as opposed to making people incur expenses. There was a study that was done many years ago, and it showed actually that it's not, people assume that with advancing age you have got increased expenditure in terms of healthcare expenses. But that study showed that it's actually dying that is expensive. All right? And dying is expensive because a lot of our patients, especially in this country, they spend 90% of their entire lifetime health expenditure in the last few weeks of their lives. There has to be something there that we need to speak to, because it might very well mean that we're deploying resources where we're not getting value. And worse still, there are times we're deploying resources and diminishing the quality of people's lives at the end of their lives when the focus needs to shift to other things as opposed to clinical treatment. So with those few remarks, I'd like to welcome the Cabinet Secretary to share with us our words of wisdom for today. Thank you very much.
Thank you very much, Chair. European Hematology Association President, President Aortic, President Kesho, Chair Shah, Chair NCI, CEO NCI, local and world leaders, including Professor Abinya, who was my mentor and the father of oncology, taught me through bachelor's degree, master's degree. Good morning. It is an honor to address this Kenya International Cancer Conference theme, Advancing Cancer Care in a Rapidly Changing World. This event provides an opportunity to celebrate our progress, reflecting on existing gaps, and reimagine the future of cancer care through robust policy shifts and collaborative efforts. Cancer has indeed become a critical public health concern in Kenya, with global trends ranking it as a leading cause of morbidity and mortality. Beyond the statistics, cancer impacts resonates deeply in households, communities, and the world at large. In Kenya, cancer is the third leading cause of death and the second among non-communicable diseases following cardiovascular conditions. The annual incidence stands at 44,726 cases, with 29,317 resulting in mortality. These figures call for a concerted effort for mitigation. The government of Kenya is committed to ensuring that every cancer patient can access quality care, including emergency services. The Ministry of Health is enhancing institutional frameworks, human resource capacity, technology, medical products, and infrastructure in line with global best practices. Achieving this requires collaboration of all stakeholders across the cancer care continuum. I want to thank Kesho for its invaluable support in service delivery and strategic interventions in resource mobilization. Through the National Cancer Institute, partnership has been strengthened to decentralize cancer services, bringing them closer to the communities in need. Our cervical cancer screening program through HPV testing, visual inspection with acetic acid have gained traction. Public education campaigns and community-based initiatives promote awareness of cancer, risk factors, and early diagnosis. Community health promoters trained in cancer prevention and control play a pivotal role in this effort. And so I want to urge all stakeholders to integrate their services into ongoing cancer programs. Equally recognizing disparities in access to care, we are establishing regional cancer centers to decongest national referral facilities such as Kenyatta National Hospital, Moi Teaching Referral, and Kenyatta University. We have operational centers in Nakuru, Mombasa, and Garissa, and will soon be joined by additional centers in Kisumu, Kakamega, Meru, and Nyeri. These facilities represent our commitment to decentralizing care while acknowledging the critical role of county governments. We are leveraging on public-private partnership to acquire advanced radiotherapy equipment and subsidize chemotherapy drugs. We hope to meet the local manufacturers and see how we can also subsidize these medications under the Social Health Authority so that our patients can equally access the very same care that we are talking about. Under UHC initiative, the inclusion of essential cancer care packages in the Social Health Insurance Fund is reducing the financial burden on families. We have the prevention by the community health promoters, screening and prevention activities, management, as well as rehabilitative practices, as well as palliative care. However, challenges persist, particularly in workforce development. The limited number of oncologists, pathologists, oncology nurses, and other specialists remain a pressing issue. Local and international academic programs are building capacity, and I want to commend Kesho for its role in professional development through CPDs, CMEs, and training courses. And the ministry, through the NCI, again, is establishing a national cancer research and referral lab to enhance patient care and enable clinical trials. We encourage you to leverage on this. Let us have more data-driven management and also data-driven prevention practices within our community. Addressing data gap is critical. The National Cancer Registry, though operational, requires continuous updates, expanded coverage, and integration with counting systems. Accurate data will inform planning, research, evidence-based care. And I want to encourage Kesho members to utilize this data to advance patient care research while supporting precision oncology. Financing remains a cornerstone of our cancer control strategy, and the ministry is adopting innovative financing models to support screening, diagnosis, treatment, palliative care, and survivorship programs. This mixed financing approach complements SHA funding to ensure sustainability. We continue to engage with global and regional partners, including WHO, USAID, IRC, and IAEA, while learning from initiatives such as the American Cancer Society's patient navigation pilot at Kenyatta National Hospital, and we hope such programs can be scaled up nationally. And so I call upon all stakeholders, cancer specialists, policymakers, clinicians, researchers, industry players, and development partners to reaffirm their commitment to cancer prevention and control. And together we can build resilient health systems, foster innovation, and ensure equitable access to care. Let us envision a cancer-free Kenya, united in purpose and action, and I pledge the ministry's unwavering support for all initiatives. Thank you, and may God bless you all. And so just a remark about the Social Health Authority. We are calling on colleagues, stakeholders to support us, even as we roll out the Social Health Authority, or now known as the Taifa Care. This will bring access, affordable. Yes, accessible, affordable, quality care for all Kenyans. And I know we have oncologists here, we have health workers here, and I can assure, let me see, maybe a show of hands, how many of you have sent patients home because they could not afford the services that they are giving? Let's be honest, There you go. All right. How many of you, as being trained maybe in medicine or any other healthcare profession, could not access the very services that you are providing? You see? All right. So now we have an opportunity for affordable, accessible, quality care. We are only 50 days into the program. We just rolled it out 50 days ago. And so gradually we look to improve the program. If this was a 1.5-year-old baby, this is not a baby who will just the baby cannot even sit. So this universal health coverage has been rolled out in very few countries with success. Currently in our country, we have political will so that we can have affordable, accessible, quality care. The key stakeholders that need to support us are those that are, they are aware of the challenges that Kenyans face. Kenyans who go through catastrophic expenditure, especially the cancer patients. And as Daktari has clearly said, quality of life is compromised, and yet they deplete their funds completely. They leave maybe their wives as widows, their children as orphans, with nothing at home because of the great expenditure that is used as they access care. So when we look at the health financing component and we are able to address universal health coverage, equally looking at quality of care by working in collaboration, in synergy with colleagues, as is in the Kenya International Cancer Conference, I believe we can come up with interventions, we can come up with strategies that should be able to support Kenyans access this very care. So we will start with accessibility. We hope to engage the manufacturers to ensure subsidized costs, because it is really heartbreaking to hear that some of the chemotherapy goes for 300,000 Kenya shillings, exorbitant prices. And so you as stakeholders, how do we engage to ensure that these prices are lowered and that each one of us can access these very services? Because you never know, tomorrow you might lose your job, or in retirement you may require these very services. We know that cancer is common in the elderly, among other chronic illnesses. And yet this is when funds are depleted as we access the care. So we are calling for your support. We are calling for your advocacy and coming up with interventions that we can put in place to ensure that this UHC, the Taifa Care, is a success in Kenya, and that we can be a best practice, not only in Africa, but globally. So thank you so much. Over to you.
Thank you very much, Waziri, for that commitment to the stakeholders in the cancer space, that we have the leadership in the country and the leadership in the ministry supporting these efforts. After this, we are going to have a closed-door meeting with partners who are in industry. Waziri would like to have a discussion so that we can continue the discussion on how we can best reduce the cost of cancer care as one of the many strategies that the National Cancer Institute of Kenya is proposing to the Ministry of Health. In that meeting, we will also have in attendance the different leadership that composes the stakeholders in this space, from oncologists, medical oncology, radiation oncology, hematology, nurses, and palliative care. With that, I would really want to appreciate everyone and hand over the program to the chair of KICC.
Thank you so much. So, Madam Waziri will invite you for photos just in front here. Then we can go on to your meeting. Karibu. Just down here. Yeah, down there. Hello? We... So, as Madam CS is leaving, we are now going into our breakouts. We are a bit behind schedule. So in this hall, we'll have A1, which is radiation oncology. So you can stay here. A2 will be... A2 is in Swiss Park. A3 is in... Aquarius. Sorry, the name had gone out of my head. So A1 is here, A3 is in Swiss Park, A2 is in Aquarius. Anyway, we'll be guided outside. The only one I am sure of is A1 here. Please pick your meal cards on your way out. And just to note that the meal cards are color coded. The ushers will be able to direct you where you go for lunch after the breakouts. Thank you very much. For the team going for CNS, please note the CNS and head and neck tracks are combined. That is in Aquarius. Thank you. So the chairs for the Radonk breakout, please, can you come so we start?
Track A2 will be in the Swiss Park. Track A2 will be in Swiss Park. A3 is going to be in Aquarius. Then we are going to have Meet the Experts Hematology in Kakamega Hall. Hematology tracks Meet the Experts will be in Kakamega Hall. Thank you.
Welcome to the International Cancer Conference here in Kisumu, Basho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Basho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu, Basho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Basho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu, Basho from November 21st to 23rd, 2024.
Hello? May I get your attention, please? Hello, all.
The aim is to boost medical tourism.
As the others are trying to settle down, we need to now proceed with the presenters. So, for the main track here is the radiologist at the
Good afternoon, colleagues. It's nice to see so many people interested in radiation. We hope that you'll settle into your seats. I'll just give the team, just as the team is setting up my presentation, could we ask participants for the Radong track to move forward, if you wouldn't mind? I can see people who I know, so I don't want to call names, so please just come up front. And I'll just be requesting my colleagues in the IT bit to put up my presentation. It had been forwarded in advance. Okay, just we have a slight technical glitch. But I think I know a little bit about auxiliary radiotherapy. I can start without my slides. So as Fred explained, my name is Dr. Waweru, clin-onc, but practicing pure radiation oncology. Some of us met in the RADONC preceptorship where we were talking about radiotherapy. This will be a continuation of that. So, you know, breast cancer we know is our #1 most diagnosed cancer and the second leading cause of death. So the management of breast cancer is an important one to get right. And auxiliary radiotherapy has been a big subject of debate and discussion amongst us. And when I just took a poll before today's presentation with some of my colleagues, the truth is it's easier to say let's treat the axilla than not. And we understand there are many reasons. We're more fearful of recurrence than we are of late effects, #1. #2, in the big radiotherapy centers where you're treating over 100 patients, 40% of those ones would be breast cancer if we have our statistics right. And you know, the nuances of looking through the pathology report, was the axillary dissection adequate? Is that pathology report exactly how we want it to be? You can understand how it's easier just to say the standard field, breast or chest wall include axilla level 1 to level 3, infraclav and supraclavicular. I just hope that in the end of these 10 minutes, we will refine some of our practices a little bit, myself included. Now, just keep going. Sorry. That's a different... it'll be difficult to talk about trismus when I've prepared radiotherapy for the axilla. Sorry. Okay, next slide. Yeah. Is it this one? Yeah. Okay, I think we're ready to start now. So a lot has happened in terms of the diagnostics of breast cancer. We all agree, right? Over the years, beyond the T size, end stage, you have the biomarker status. There is the like predictive scoring for systemic treatment. Predictive scoring for radiotherapy is also being developed. But one thing remains true: the status of the nodal disease remains one of the main prognostic factors for patients with breast cancer. So how we manage that is important to standardize. My opening statement, I think is pretty obvious. You need the MDT in all of these patients. There are pretty good sessions this afternoon about the MDT in management of cancer patients. For breast cancer, we know in terms of treatment, not only do we need the surgeons, radiation oncology, medical oncologists, you need your radiologists and your pathologists. Adjuvant radiotherapy, there are several studies over many years that show that it reduces the risk of disease recurrence, both locally, regionally, and improves overall survival. I will just maybe quote the EBC-TCG meta-analysis that was published in The Lancet in 2023 that looked at over 10,000 women. The data is still the same, that more than 50% reduction in recurrence, local regional recurrence after breast conserving surgery, and reduces mortality by about 1/6. And of course, within that, if people have high risks of recurrence, those statistics are even bigger. Now, broadly speaking, my 10 minutes will be divided into 2 categories. Auxiliary radiotherapy after breast conserving surgery, auxiliary radiotherapy after a mastectomy. So for BCS, we know that a sentinel lymph node biopsy since the 90s has been accepted as a reasonable approach. In fact, preferable for patients who have node negative clinically to start off with. Obviously, there is the issue of personnel and equipment that limits who is doing sentinel lymph node biopsy, but we're just presenting what the gold standard would be. Now, the NSABP B32 study is what showed us that if you're clinically node negative and do a sentinel lymph node as opposed to axillary node dissection, your over DFS, OS is the same, quality of life is improved. So where possible, SLNB is what we should be doing. Now the question arrives for us in radiation oncology, there are 2 main decision points after SLNBP. Where it's pathologically positive, do you go on and do dissection or not? Or do you give radiotherapy? And the second decision point to make is, if you're going to give radiotherapy, what are you including? Are you including level 1 to 3, infraclavicular, SCF? What are we doing? So just a few studies that have helped us with this. So if you have isolated tumor cells in your sentinel lymph node biopsy, the treatment ends there. You've done BCS, SLNB, you really don't have to think of managing the axilla further. And if you have your SLNB with 1 to 2 positive sentinel lymph node biopsies, really there is no requirement to go in and do a completion of your dissection if you're going to do whole breast radiotherapy. The reason for this is the 2 studies, ASCOG Z11, IBCSG 2301, showed us that these patients do okay after your SLNB and just your whole breast radiotherapy. We all know here that your tangents, your right lateral, left lateral, maybe your field in field, will give a therapeutic dose to your axilla, right? So microscopic disease will be cleared there, and that is why those patients who just did your SLNB and just went to whole breast radiotherapy had no increase in recurrences. So if you have 1 to 2 lymph nodes and you're going to whole breast radiotherapy, there is no justification to do proper dissection, or in fact intentionally go to treat the regional lymph nodes. Your tangents will cover you. If you have more than 3 lymph nodes, however, we recommend doing a formal axillary dissection and then proceeding with the adjuvant treatment there. I've sat in tumor boards where some of our surgical colleagues have talked about the AMOROS trial as a justification for saying, yes, they have 3 sentinel lymph node positive, you can just go ahead and give radiotherapy. But the AMOROS trial that looked at ALND versus dissection when you had positive sentinel lymph node biopsy, 95% of those patients had 1 to 2 lymph nodes. So I would argue that we don't have the data to do that yet. So when now you've decided, the first decision point is this patient has 1 to 2 lymph nodes or more positive, you're going to give your adjuvant radiotherapy. What exactly are you treating? Most studies, when they talk about regional radiotherapy, are actually talking about level 3, infraclavicular and supraclavicular. So the point here is our gut instincts as radiation oncologists is they have a 1 to 2 positive sentinel lymph nodes. You want to treat the entire axilla, SCF. Let's just remember, for patients who have a lower absolute risk of recurrence. Sorry, I haven't moved my slides across. Yeah, so for patients who have an absolute lower risk of recurrence, treating the entire axilla will increase your morbidity. And we had one of our survivors here, I think Jane this morning, who is living with and managing lymphedema. So let us be careful in justifying where we're giving axillary radiotherapy. So what the studies would tell us is that you're looking at your primary tumor to guide which levels of the axilla you treat. If you have a T3 or T4 tumor, give your regional nodal radiotherapy. If you have T2 with other high-risk features, grade 3, ER negative, LVI, extensive intraductal component, you're justified in giving your regional radiotherapy. A lot of us will be aware that the Taylor RT trial is ongoing now, that is looking at things like the oncotype scoring to guide us on where we should use regional radiotherapy. I think we will standardize our work then, but we all know oncotype now is about $3,000. Not many people will be able to afford, I think, the scoring system that's coming, but it'll at least give us some guidance for those patients who can afford it. So we've covered breast conserving surgery with sentinel lymph node biopsy. Just to summarize, isolated tumor cells, you don't need to do any further. 1 to 2 positive sentinel lymph node biopsies. Your tangents for whole breast radiotherapy are sufficient. More than 3 sentinel lymph node biopsy, please go ahead and do your formal axillary dissection and then proceed with your adjuvant radiotherapy. Regional radiotherapy is, in most studies, is infraclavicular, level 3 supraclavicular. You can consider the axilla if the primary tumor is looking like it has a lot of high-risk features, and you can justify the late toxicities. In some studies, lymphedema is as high as 40% when we add radiotherapy. So now we're looking at BCS and axillary lymph node dissection. So again, we would say that I think the MA20 and ERTC 22922 study has told us that if you have any macroscopically involved lymph nodes, we suggest adding regional radiotherapy. Now, this is subject to big debate. Most of us in our minds know if there's 4 lymph nodes or more, you're going to give the entire regional radiotherapy. 1 to 3 different consensus statements being given. But I think for our practice here, knowing what the cost of recurrence would be, one can justify giving radiotherapy to the regional lymph nodes. Obviously, if it's like 1 lymph node, we know the benefit is 1 to 2%. 2 to 3 lymph node, the benefit is about 2 to 3%. And more than 4 lymph nodes is more than 5%, right? So I think it's about also being clear of what our population looks like, what the cost of that recurrence happening. I think one can justify giving axillary lymph node radiotherapy. So again, the definition of regional radiotherapy in most of these studies is supraclav, infraclav, and if you're concerned about the extent of axillary dissection, you can also add axillary radiotherapy there. I think we covered that other point. What about micrometastatic disease? Again, you know, I was just picking out the things that we find difficult to comment on in tumor boards when there's a lot of pressure on the radoncs to answer. So 1 to 2 micromets, consider that patient as if they're N0 and let the primary tumor guide what you're doing. This again was based on the Z11 study predominantly, where we said the whole breast tangents would cover your axilla. But if they have limited micrometastatic disease, but the primary tumor, the biomarker status are not looking too good, again, there's justification in giving your regional radiotherapy. If they're node negative, again, it's considering what the primary tumor looks like. We've talked about T3, T4, T2 with high-risk features. Extensive intraductal component is kind of the latest thing we're now starting to look at. And if there are any pathologists in the department, in the talk, we would strongly advise that you now start indicating EIC because we're not seeing that uniformly in all our path reports. Neoadjuvant systemic treatment, this is another difficult one because we're often being asked, they've achieved pathological complete response because of the great systemic treatment that our medoncs are giving. Can we justify treating path CR as if, you know, same as people who have not achieved path CR? To be honest, we don't have the data to omit or limit radiotherapy in these cases. So go back to your index staging to guide what you're doing. There is the B51 trial that will hopefully tell us whether we can de-escalate radiotherapy in patients who have achieved path CR. But for now, your index staging will be what guides you. So that is now the completion of the first half where you've had conserving treatment. So we're just going to go to the second half, which is post-mastectomy radiation. And again, a little bit like breast conserving surgery, our gut feeling is if they have any lymph nodes, you need to treat everything, level 1 to 3 supraclav, but we would just like to refine what we're doing. So if patients have had complete axillary dissection, I'm not quite certain we can justify treating level 1, level 2, knowing how much will increase the risk of lymphedema. So let your primary tumor guide whether we're doing this. In terms of internal mammary, there'll be one slide at the end that says, let's adopt an individualized approach. We have like 2 schools of thought. Some people, unless the internal mammary lymph nodes are involved on the index imaging, they won't treat internal mammary. Others will always treat the internal mammary, and then there's the rest of us who are somewhere in between there, making a decision based on the patient in front of us, and I think that is the better approach. So node positive, again, the MA20 and the early breast cancer trial group have demonstrated really that from lymph node 1+, there is benefit in giving post-mastectomy radiotherapy and including the regional lymph nodes. But we just need to be aware that there's a difference in benefit whether you have 1 lymph node and a small tumor, 2 or more lymph nodes, 4 or more lymph nodes. And it's having that data available to us so that when we're speaking to the patients, we can give them the benefits versus cost and make an informed decision together. So yes, 1 to 4 lymph nodes. My personal practice is I am offering regional radiotherapy, at least to the chest wall, level 3 supraclavicular. Whether I treat level 1 or 2 depends on the extent of the dissection, what percentage of lymph nodes were positive, whether the axillary fat had microscopic disease, and I think that's the practice most of us are doing, and that seems to be a reasonable approach supported by data. So for node negative, I think we're all aware that you're going back to your primary tumor to determine. If you're T4, we're treating the regional lymph nodes. If you're T2, you're looking for other things, triple negative, high-grade LVI, to determine whether you include it. Yes, so that's kind of saying the same thing. Neoadjuvant therapy, the statement is exactly the same as that for breast-conserving surgery. We still don't have I think, robust evidence to de-escalate treatment in patients who have achieved pathological complete response. So our practice remains until studies tell us otherwise. Now, internal mammary nodal, I alluded earlier that I've seen every practice, and even myself, from week to week, the practice changes. So I think this is a good defining statement, that your risk of internal mammary lymph node microscopic disease approaches 40% in some studies if you are axillary lymph node positive and you have a medial tumor. So I think we should gradually move towards including our IMN. And I say gradually move towards because there's more than just what the studies are telling us. As the RADONC, you need to be confident about your median cardiac dose, your lung dose in determining whether you're going to include the IMN or not. And you know, our capabilities differ from department to department, so let that be your guidance. Obviously, if the IMN is positive on imaging, then you want to go ahead and give that. So those are my references, and I think I've done 10 minutes. I've tried to keep to time, and we'll have questions at the end.
Wow, Angela, that was quite a great talk, and it's always nice listening to you giving radiation therapy talks, and quite key points there about MDTs, key in management of breast cancer, and about the high-risk features that we should consider when doing nodal irradiation, and as well on post-mastectomy, on node-negative disease. The primary tumor should always be a guide. So before I introduce the second speaker, my name is Fiona Adagi. I'm a clinical oncologist, and I work in JOTRH. So it's a pleasure and honor to introduce our pioneer and legend in radiation oncology, Dr. Catherine Nyongesa Wata. She is a clinical and radiation oncologist at Texas Cancer Center in Nairobi and Kenyatta National Hospital with a 10-year experience in oncology, conducting inpatient and outpatient management of cancer patients. She has a bachelor's degree in medicine and surgery at the University of Nairobi, Masters of Medicine in Radiation Oncology at the University of Witwatersrand in South Africa, and a fellowship in Radiation Oncology from the College of Radiation Oncologists in South Africa. Among the key organizations, she has been a member of the American Society of Clinical Oncology, Health Professions Council of South Africa, and International Gynae Oncology Society. Welcome, Dr. Catherine.
Thank you so much. Thank you so much, and good afternoon. So I am going to take you through an ongoing study at the Kenyatta National Hospital, which is evaluating the impact of HIV on non-inferiority of accelerated hypofractionated radiotherapy in treating cervical cancer. It is also known as the ENHANCE study. So, as we are aware, cervical cancer poses a major health challenge globally, especially in low and middle income countries. In Kenya, it remains the leading cause of cancer-related mortality among women. Despite efforts, patients often face delays in accessing radiotherapy in most sub-Saharan countries, and even here in Kenya at the Kenyatta National Hospital. It's not moving. It's working, thanks. So on the background and rationale, why this study, cervical cancer in Kenya, we see over 5,845 new cases, and unfortunately 3,500 of these patients succumb to the disease. Majority of the patients are diagnosed at advanced stages, limiting treatment options. At Kenyatta National Hospital Cancer Treatment Center, we see that it's the most common female cancer in the women, and we see about 468 new cases. And the sad thing from the data, only about 50% receive the treatment. And why is this? So we think there are major access challenges for the patients. Majority are diagnosed at advanced stages, so they may not make it to receive the radiotherapy. Also, we do have limited resources of radiotherapy, and this translates into a long waiting time. This study had various objectives. The primary objective was to determine whether the standard 45 gray in 25 fractions and accelerated hypofractionated radiotherapy 45 gray in 20 fractions are equally effective. The secondary objectives were to assess cost effectiveness and the impact on the radiotherapy waiting time, evaluate patient adherence and convenience, understand the prevalence of HIV in cervical cancer and whether it has an impact on outcomes. So this is a phase 3 study, and it's currently enrolling patients with stage 1B3 to stage 4A cervical cancer. And arm A, which is the test arm, they get 45 in 20 fractions with brachytherapy 9 gray times 2. While the standard arm, they get 45 in 25 with brachy 8 gray times 3 sessions. So the research questions are, does accelerated hypofractionated radiotherapy improve access and efficacy for cervical cancer patients? And the secondary research question was to examine the differences in outcome, adverse events, and cost effectiveness. And then to assess the quality of life, adherence, and outcomes for the subgroups affected by HIV, and also based on stage and age. So currently, when we look at the demographics of the patients enrolled so far, 86, with 44 in arm A and 42 in arm B, we see that majority of the patients are presenting in stage 3C disease. The average age for these women is 48 years. And the histology, 89.3% are squamous cell carcinoma, 18% of the patients are HIV positive. We have noted certain barriers. One is that there are delays in completing treatment due to blood transfusions. So patients really struggle with blood transfusion. So that's one thing that we may need to look for in terms of addressing as a barrier. And others, after they have exhausted the NHIF cover, because NHIF has been covering 2 sessions, so they go now looking for money for the 3rd session, and that causes a lot of delays. In terms of being aware about HPV vaccination, 53% of the patients are actually aware that it exists, but unfortunately none of them has ever received HPV vaccine. On socioeconomic factors, majority of these patients are of low socioeconomic status, they are married, and we've also noted that the contraceptive use is very high. 74% of the patients have used contraception. And then in terms of completing treatment, patients in the test arm, 86.5% of them complete treatment within the 8 recommended weeks. However, on the standard arm, the percentage is slightly lower. When we look at 6 weeks, 77% of the patients in the test arm, the hypofractionated arm, have completed treatment, while only a smaller percentage complete the treatment within the 6 weeks. And as I told you, majority maybe go to look for money for the third fraction and the remaining 5 sessions, because NHIF previously was only paying for 20 sessions. In terms of the external beam, comparing between the two groups, we see that the CTV coverage, the hot spot and the cold spot, the variation is not so much between the two arms. And on brachytherapy, as we see, there's a slightly lower dose with the test arm, but we don't know whether this will translate into clinical outcome. But the BED for the test arm is 62 and the other one is 60. So as I've said, we've seen that arm B, which is the standard arm, is within the Quantec study, the Quantec standards, but the test arm is slightly low because we are hypofractionating. However, the two arms maintain safer doses for the critical organs. In terms of parity, many of these women are multiparas, but not those multiparas we used to think of 10 children and above. Many have just about 4 children on average. And then majority of the patients come to hospital with PV bleeding. That is when they seek attention. And PV discharge a smaller percentage. The unfortunate thing is that it is taking these women an average of 8 months from the time the symptoms started before they come to Kenyatta for radiotherapy. And there's a range of 2 to 36 months. And these delays, the patient says one is because of being misdiagnosed. They are told you have hormonal imbalance. Others talked about the doctor strikes. Others said we didn't have money to go to hospital. So in summary, we see that there's a higher treatment completion with the patients getting fewer sessions. On side effects, we are still analyzing, but the standard arm, because they are taking longer, they are exposed to side effects for 5 weeks, while these ones are just completing treatment within the 4 weeks for the external beam. The waiting time for accelerated treatment, we're hoping that we are going to reduce the waiting time on the machine so that we align with the World Health Organization target, the one whereby at least 90% of the patients should get access to treatment when they have cervical cancer. Some of the barriers we are seeing is financial, the travel distance. Many of them come from beyond 20 kilometers. And then blood transfusion is a major problem, because you tell a patient, go for blood transfusion, they disappear for a whole week. Then they now come back to complete treatment. Renal complications. You know, being stage 3, some have renal complications, and we need to strengthen our healthcare infrastructure to ensure we take care of our women on the blood transfusion issues and renal issues. They have hydronephrosis, they have renal failure, so we need to have enough renal dialysis machines and also interventional radiology services. There's also healthcare failures making them delay. One of them is that there's limited resources, as we mentioned. Then sometimes the systems just shut down. The SHA system can shut off and patients will delay in getting treatment on that day, and some end up going home without treatment. Sometimes the eCitizen platform fails and patient cannot access treatment. We also looked at impact, whether it is going to be impactful, and for the financial year 2023-2024, the second quarter, our waiting time for radiotherapy was about 49.96 days. By second quarter, the time dropped to 40.05 days. The fourth quarter, unfortunately, we had a doctor strike, so the waiting time was very short. We are just clearing the backlog. However, in the quarter one of this financial year, we see the time, waiting time is reducing. And we are hoping that with hypofractionation, maybe waiting time will still continue being less and less for the patients. And of note, also we are running a study on hypofractionated breast radiotherapy. So this may also have an impact. So on significance, I think we need, in improving accessibility, accelerated radiotherapy offers faster, more accessible options and supports the World Health Organization 90-70-90 targets. Because if you have patients, we need to move them through the radiotherapy so that other patients can come, and we strive towards that goal. It is a potential model for other low middle income countries, and also from the study, it is highlighting the need of HPV vaccination. So it is a hypofractionated radiotherapy is a cost-effective alternative. On recommendations, we need to invest in radiotherapy infrastructure, HPV vaccine awareness. You see our population still lags behind. We invest in HPV vaccination so that cervical cancer is a thing of the past in the coming years. And we need to enhance hypofractionated protocols. If they work, we have to work with evidence-based. Enhance blood transfusions in our hospitals and renal failure interventions for these cancer patients. And probably also move towards navigating these women with cervical cancer, because they are coming so late with all these complications. And with all these efforts, we'll work together in supporting the World Health Organization goals on patient outcomes. And also we hope this study to be on a larger scale to validate the findings and see about early detection strategies. I take this opportunity to thank the KNH Cancer Treatment Center team, the study participants, and the KNH research and programs for their invaluable contributions. Thank you very much.
Thank you so much, Dr. Catherine, for that detailed presentation and the key points there. And it will be interesting to later on wait for the audience, at least the questions that will be asked in that interesting study. At least a key point there, hypofractionation is a cost-effective modality in radiotherapy. Unfortunately, our third and fourth speakers are not with us today, and I'd like to introduce our last speaker, Grace Macharia. Grace Macharia is a speech therapist at the Aga Khan University Teaching and Hospital, and she will take us through the managing radiation. She'll take us through managing radiation-induced trismus in head and neck cancer patients in Kenya, a step-by-step approach. Welcome, Grace Macharia.
Good afternoon, everyone. I hope my voice does not give in. I've been having a cold and how do I go about this? Okay. So I'm very delighted to be in this space because when I was seated there, we were talking about quality of care of our patients, and a lot has been said about medical background and palliative care, but very little about rehabilitation. So this is presenting a paper that was done by Duncan Muzasisi. He's a fellow's colleague, a speech therapist who done managing radiation-induced trismus in head and neck cancer patient, and a step-by-step approach. So he did some research. It's not moving. It's not moving. Okay. At the background, he was looking at radiation therapy is an important treatment for treatment of head and neck cancer in both malignant tumors associated with and associated with complication of the disease. And radiation is also associated with the drawback of getting potential development of trismus, that is radiation-induced trismus. And the prevalence is that from his study, he actually did not get any paper that is actually any research paper that is done in Kenya in terms of utilizing therapy-based framework. And he checked in comprehensive search of papers from the PubMed, Medline, and Google Scholar, employing the keywords radiation-induced trismus and Kenya. The aim of the study was to describe management in radiation-induced trismus in low-resource setting, like a place in Kenya, utilizing experience-based learning and highlighting practical strategies and challenges that we encounter in clinical practice. So the research question was, what are the effective management strategies for radiation-induced trismus in low-resource setting, such as in Kenya, and how can clinical experience shape the approaches? And the result is that a lot of people who undergo radiation end up having eating and drinking difficulties, difficulty in speaking, and jaw pain, tight jaw muscles, and poor dental and oral hygiene, and psychological problems. Other risk factor could be because of tumor, radiation dose, and the previous limitation of jaw opening, mouth opening previous to the treatment. Before I continue, I would like you to just put yourself in this scenario. Think of how you enjoy eating your foods. If you like apples like I do, you'd like to bite into it other than cut it into small pieces before you put it in your mouth. If you're from Western Kenya, I believe you love chewing sugar cane. And for you to be able to enjoy it, you really have to open your mouth wide. I hope your hands are clean. Just try and put your hand, one finger in your mouth. See how easy it is to do that. Put 2 fingers across, putting straight like this, one on top of the other. Put 3 and 4. It's a little bit harder. If you can be able to open that, actually on average, 3 fingers are the ones that you are able to open your mouth comfortably. But can you imagine, because of having head and neck cancer, your jaw cannot open that much. And because of radiation, and most probably because of the pain you'll experience, you actually stop opening your mouth that much because of the pain you're feeling. And as they say, if you don't use it, you lose it. So unfortunately, as a speech therapist, I would say that most of the referrals we get are usually too late. We usually get patients who cannot even put 1 finger in their mouth. And we are expected to help them to improve the range of motion. So you can imagine what that means, that they cannot be able to eat the food they would like to eat. And so most likely they're going to use straws or blended food. And in our case, from experience, people, when we give them blended food, they think that is child food. So they really don't enjoy it. And if it happens in hospital, most of the time we find that blended food usually is not even tasty. They don't put, because it's supposed to be put through NG tubes and PEG tubes. So it's usually not prepared that well. So you can imagine your quality of life of that patient, what will happen to them. So is there a way we can be able to, is there a way we can be able to help in managing these patients? So management plan is, if we are invited, these patients are referred to us as speech therapists early in advance, before even treatment is started, then we can be able to take the case history, do physical examination, And of course, radiographic evaluation and imaging is very key so that we get to know what are we working with, what is the range of motion, and then consult a multidisciplinary team. I've heard of multidisciplinary team being mentioned, and mostly it's doctors, but I've hardly, apart from one physiotherapy I had today talking about working with the lymphedema, we have the rehabilitation team, the physiotherapist, the occupational therapist, the speech therapist, and counseling, dietitian, and of course, get psychological support. And assessment, what kind of assessment do? We do manual assessment tool, that is the three finger test. And also we have terabyte range of motion, and assessment scale tools like the Vero host index. If it is more than 4.5 pre-radiation, is likely that the person who is going to undergo radiation, they are likely to get jaw necrosis. So that means their jaw opening is going to be affected. And the pain scale, rating scale is also important, so that we get to know that if they are experiencing so much pain, then we need to refer them to the doctor so that they can be given medication. So, because pain is not one of the things that we want to have with when you're doing rehabilitation. So the question is, what are the effective management strategies for radiation-induced trismus in resource setting in Kenya, and how clinical experience approach advises on this? So these are the therapy options. We have jaw expanders. And if you look at all these gadgets, they're actually not locally available. And as you can see, the last one with those are a pack of tongue depressors. So we use tongue depressors to put them interdentally, so gradually increasing the number so that we can keep on increasing the range of that. So that is the main tool we have locally. But does it mean that because we are in low-resourced country that we cannot be able to get these other tools? I don't think so. Because among ourselves, I can imagine how many of you are using iPhones. They're pretty expensive. So does it mean that even if we come from Kenya, we cannot afford some of these treatment tools? I guess we can. So I would like to challenge instrument providers, whether they can be able to source for us this equipment tools so that we can be able to have exercises that can be, we can combine passive exercises as well as functional exercises. And passive exercises is where we are going to use these tools to expand their jaw, and then we can also use other things like chewing gum, chewing nut. I know of a patient, one of the patients we've been working with does not like using chewing gum, but we prefer chewing nuts. And then they'll chew, and then spit if he is not able to swallow. So something that is functional. And when it's functional, it improves in helping us to improve increasing the range of motion, or maintaining it if possible. Instead of losing it, we maintain what we have other than making it worse. And so what are the challenges? We have cultural practices where most people we work with don't want us to open into their, to check into your mouth, into their mouth. And another thing is that a lot of doctors hardly check in their patient's mouth. So I would challenge you to make it a practice. Check in your patient's mouth, because in most cases you'll find that even oral care is not even being done. And if your mouth is, you're not eating orally, if you're feeding via tubes, and you're not eating and you're not most likely talking that much, bacteria growth increases very fast. So within a very short time, ideally we are supposed to do oral care 4 hourly, but it's hardly is ever done. So if you look at their mouth, it's very, very gunky. And if you have a dirty mouth, most likely you won't want to swallow your own saliva. So this does not improve on their quality of life. And the other challenge we have is a lack of referrals. Like I've said, we have we have very few patients who are referred to us until it is too late, and when they actually cannot be able to talk and they cannot be able to feed. But if we see this patient before even treatment has started, I think there's a lot we can do to give them exercises that can help them maintain their range of motion, and as well, if not improve it, at least we can be able to assist so that at least they can have better quality of life as they continue through their treatment. I've also mentioned about lack of equipment and economical barriers because cost of therapy. I work in Aga Khan Hospital, and a speech session is over 7,000 shillings. How many people can afford that? So what are the people who cannot even be able to afford treatment? And now we are talking about therapy that is so expensive. So we need to think in terms of, I believe it is because there are very few speech therapists, but if we can put our hands and heads together, encourage the government to get involved in this so that we start having local training so that we can improve the number of speech therapists that can work with this. Recommendation is evidence-based practice. So MDT is crucial, and both passive and active dual exercise are important, and imaging is key. The person who wrote this paper, he has over 9 years experience of dealing with clients who have radiation-induced trismus, including he was working in Kisumu before he came to Nairobi. He has only managed to see one patient in Nairobi, in Kisumu about 9. And before he had seen about 30 clients in Kampala. It looks like Uganda is doing better than we are doing. So it's our challenge. Doctors, refer these patients to us so that we can help you better quality, good results for your good work you're doing. Thank you.
Thank you, Grace, for your detailed and quite interesting talk. And as we are winding up on this session, I'd like to appreciate all the speakers who have taken us through this session. And as we are getting into our Q&A section, just to start off by asking Grace, for these patients, how soon should we start the exercises to avoid the trismus?
If we get to see the patients before they start radiation, then we have exercises that we can be able to give them so that they can be able to retain what they have or even improve on it. And then during the radiation process, then they can keep on doing this exercise, because due to pain, most of them don't want to open their mouth. But if we have something that is already ongoing and they know the need for it, and counseling is done, and being able to, pre-counseling is very, very key, so that they get to know what they are looking forward to or what they are going to go through. And then we have this exercise them doing, then they'll definitely have a better impact.
Thank you. Do you have questions? Thanks.
Good afternoon, everyone. Thank you to the speakers for very enlightening talks. I have two questions. One is to the first speaker, Dr. Angela. So it's just asking for your opinion, not necessarily that there's data, but we know primary, that is in the medial aspect of the breast, it's inevitably going to cause an internal mammary chain lymph node, and not necessarily cause axillary lymphadenopathy. So that stages the disease as 2, and 2, has its own protocol of treatment. But again, it's just asking for your opinion in terms of avoiding the morbidities that is associated with axillary radiotherapy. What would be your opinion in managing this very early, maybe T1B inner quadrant disease?
Yeah. I think the practice for all of us would be to include the axilla. It still remains the predominant lymph node spread, even for inner like medial tumors. So now the question is axilla plus or minus IMN. So I think it would be very unusual to treat whole breast internal mammary and not consider your other regional lymph nodes. Data exists to say that you will still be concerned about microscopic disease in the axilla, even for medial tumors.
Okay, thank you for that. And for Dr. Nyongesa, it's about the trial. Well done on that. And my question would be, just extrapolating from the rectal cancer data that we are hypofractionating, or the short course radiotherapy of 5 fractions, I just wonder if 20 fractions versus 25 fractions of cervical is very much different to the 5 fractions versus, is it 28? I'm not so sure, for the rectal. And would that be more meaningful in our population in trying to answer this question of accessibility?
Yeah, definitely it's all on research basis. Like in Kenyatta, we've been doing 50 gray in 25 fractions for a long time, but then we noted that many of the patients were getting fistulas when we get to brachy, because we are not, it's like we're giving a high dose. So that is why we are trying to de-escalate to see. But obviously there are other studies which, I saw there's one study even trying to look at 15 sessions. So all those are practical possibilities. We just need to identify which patients are fit and looking at other factors. For example, if a patient has severe renal failure, then probably that's a patient you need even to hypofractionate more if you cannot correct the renal complication. A patient coming pouring blood, what do you do with them? There are people who also try to hypofractionate the first few sessions.
Dr. Nyongesa, if I may, I've read some studies that talk about the increased risk of brachytherapy toxicities above 7 gray. I know most of us, our local practice would be 8 gray per fraction. And again, we have to be very cognizant of our
Studies who are doing 9 gray times 2. There's an IES study also did 9 gray times 2, and they found it's quite safe. So we are trying to reduce the sessions of brachy by pushing up the dose.
I guess. Something that may need the surgery, and we may not necessarily have to get in touch with that. We cannot be able to work on that until everything is done. Because that helps us to know what kind of exercises we give them before treatment starts.
Okay, my question maybe is it a plain X-ray? Is it a CT scan? Is it an MRI?
My guess is a CT scan, but when we do modified barium swallow, we can also do fluoroscopy studies so that we see the movement of how they're feeding before. And as a speech therapist, we do modified barium swallows, not barium swallow. It's a difference. Modified barium swallow, we put barium into different consistencies so that we see how the mouth is interacting with the food, the actual feeding exercise live as we see it, so that we see what range of motion in terms of chewing and in terms of tongue mobility, and also in terms of airway protection. So fluoroscopy studies, modified barium swallow.
Okay, thank you. Maybe my last question to my senior, Dr. Nyongesa. That study, is it still recruiting or it's closed? And when are you expecting the results? Thank you.
Yeah, thank you for the question, Dr. Okumu. So we are still recruiting. We are targeting 140 patients first. So we are currently at 80 something, so we are beyond halfway. So we expect the results, maybe slightly more mature results in the next Kesho conference. Thank you.
Okay, Dr. Yambo.
Yeah, my name is Dr. Dan from KMTC Nairobi. My first question goes to Grace. Most of these patients with head and neck cancers, you find we send them for oral care to the dentist before the treatment. Is it advisable that we send these patients also to you guys for maximum mouth opening dynamic studies before they commence the treatment? And if that is the case, how available are you guys in terms of providing these services? And then the second question goes to Dr. Catherine, who happens to be actually my mentor in terms of matters oncology. I have gone through your Wikimoja radiation study, of which is a hypofractionated kind of clinical trial. But most of these patients, again, you find they have low HB, especially patients with cancer of cervix. What is the recommended HB, hemoglobin level, that you can commence any patient for radiotherapy? And is there a role of hemoglobin in terms of functionality of radiotherapy towards reciprocation of cancer cells to treatment? Thank you.
Thank you for your question. I would suggest that oral care for the major oral care can be done by the dentist, because they're the ones who will be able to do the intricacies of even working on the cavities and the like. But on a day-to-day basis, those are the kind of oral care we work with, and we work together with the HCAs as well as the nurses, the nursing team. And I smiled when you asked how available we are, because I believe there are only 3 speech therapists who work in hospitals in the whole country. So, and we're overwhelmed by even what we do, because dysphagia work is not done by just general speech therapy. They are clinical. It's a clinical, you have to be clinically trained to manage dysphagia, and we don't have many done because it's not available locally. And in fact, for some of us had to go out of the country to do that. So the biggest challenge we have is that even the training that is locally available is more of the language, the speech language that deals with the language bit other than the clinical aspect. So one of the biggest challenge we have is getting speech therapists who are who have mentorship in clinical space. And for the little we are being able to do, like where I work, I try as much as possible to educate the nurses as well as the health care workers to be able to do a day-to-day oral care, because if that is ignored, we end up finding that a lot of our patients will end up getting aspiration pneumonias, not because they're feeding orally, but because their oral care is poor. And so one drop of dirty saliva getting into the airway you'll develop aspiration pneumonia, whereas we can prevent that if we have very good oral care done.
So thank you for the question about Wikimoja. Actually, Wikimoja is a breast cancer study, and I will present more about it tomorrow during the rapid fire. For the cervical cancer patients and HB, studies have actually shown that patients respond, the cancer response rate is better with a good HB of 12 and above. But in our setup, we accept 10 and above. Yeah, but some studies actually also say 8. So 8, but ensure that you are going to transfuse the patient with a target of hitting at least 10 or more, but the target should be 12. And that is why we are recommending that based on this study, our patients are really suffering, going to look for blood. We need to strengthen blood transfusion services and renal services for us to get good outcomes for the cervical cancer patients.
So just, Dr. Catherine, any comment on other, IV iron, for instance? Because blood transfusion, I think, universally is difficult to achieve in a timely manner. But what about other products as alternatives?
So yes, other products, hematinics, most of them are on hematinics, but they take a long time to boost the HB. And there are also those injectables to boost the HB, but they take time. And for cervical cancer patients, we have a timeline of 8 weeks to complete treatment for you to get meaningful responses. So the blood transfusion is a quicker way and timely treatment. When we delay treatment, patients continue bleeding. They transfuse. Some have come to me, they said, I've been transfused, so I think 3, 4, 5 times, but she has not initiated on radiotherapy. So we want to initiate radiation as soon as possible because it is one of the treatments for stopping bleeding. Radiation is a very good hemostatic treatment. So it is more of timeliness and availability of the resources.
Okay, good afternoon. My name is Gura James. I'm a medical physicist from Nakuru County Referral and Teaching Hospital. My question goes to Dr. Nyongesa. In this hypofractionated treatment, have you tried to look at the constraints and development of the constraints with regard to comparison on the conventional treatment of 45 grays in 25 sessions in order to cater for the radiation toxicity level to the organs at risk?
So yes, we are working with a team. I have a team of physicists on the study. We have RTTs, and those are things we are analyzing. So for now, we just have preliminary results, but I'm sure as things go on. So currently, what we are seeing is that the dose to critical organs is equivalent for the two arms, and also it is actually conforms with the Quantec recommendations.
My name is Misiko Alan from JQuat. First of all, my comment is to the speakers. That is commendable presentations that you have done. So my question is to Dr. Nyongesa. Can you kindly comment on concurrent chemotherapy while you are administering the radio?
Thank you very much. That's a very good question. We are giving, for those patients eligible to concurrent chemo, they are getting standard chemo, the recommended 5 cycles. But also, I've noted that patients are not completing the recommended chemotherapy cycles. Number 1, because of they are going away for blood transfusion. Number 2, also when they finish the external beam, if you've delayed a bit and you finish the external beam, when they go to get chemo, they are told no, because this should be on concurrent basis. But yes, the standard chemo is being administered to patients. So the thing is, you have to optimally have good HB, WBC platelets, renal function. Some have renal challenges, so they are not fit for the cisplatin-based chemotherapy. But studies have shown, and those are the NCI studies many years ago, in 1999, that adding chemotherapy to standard radiation for cervical cancer has a survival advantage.
Sorry, just to add, I know I'm asking more questions than the audience. We've always been told that once you're hypofractionating above 2 gray, adding the concurrent component increases toxicity significantly more than when you're 2 gray or less. But it sounds like you've not really seen that with 2.25 per fraction.
Yes, I've not seen it, but most of the patients, with the hypofractionating, they are getting 4 cycles. And the standard arm, they are getting 5 cycles. So there is a balance. Thank you.
Good afternoon. My name is Nancy Mokera.
Sorry, just a second. Do we have any other question for Grace? Because she has to go for another talk at the aquarium.
Okay. My name is Nancy Mokera. I'm an RTT from KNH. I'm part of the team in the ENHANCE study. Just to respond to the question on oxygen, on hemoglobin, there are 4 R's in radiotherapy, and there is reoxygenation. That's the main aim where we need the HB to be above a particular level. And then someone has asked about toxicity. Our study gets to 45 grays. When you look at the Quantec level, when we're starting with the first primary treatment, we're keeping it quite low as compared to the 50. Thank you.
Great. I don't know, do we still have any other question? Okay, let me come.
Thank you very much. Great presentations. My question is to Dr. Nyongesa. Dr. Misheni, your presentation, most of your patients were stage 3C2, if I heard you correctly. That means the paraortic nodes were quite involved. How will that affect the results of your study? Thank you.
So my study is building on the HEROIC study, and they included patients with stage 1B to stage 4A. So patients with paraortic nodal involvement, they are being irradiated the paraortic area, and we've not seen any undue toxicity with the hypofractionation treatment. So yes, we are treating them. But once you have the paraortic nodes involved beyond L2, that pushes the patient to stage 4B, and they are excluded from the study.
Can we take one last question and we can wind up the session? Thank you. Any burning?
Sorry, Dr. Nyongesa, you've received the bulk of the questions. But I'm thinking about running a study like yours in a center where there's no standard of care in terms of, there are so many confounding factors, the doctor's strike, perhaps the machine breakdown, things that make patients delay treatment. And I'm thinking perhaps that could affect the outcome of the study in terms of like maybe if you expect positive outcome, but there are so many other factors other than the fractionation dose, which is what you're looking at. How are you able to ensure that these confounding factors like treatment delays do not really affect your study, or how you compensate for them? I mean, thinking as a layman, maybe do you drop out patients who've maybe delayed for too long, or how do you go about that? Thank you.
So for those kind of patients who delay for too long, we'll have to do a subset analysis to see the outcome. But I think being in the field for many years has liberated me in certain things. And they say when you are doing a study, these are actually things you know the problem, but you need evidence, or you need to document them. So that is why we need evidence to show that actually 4 weeks could be equivalent to 5 weeks, but I don't have any basis. And maybe 2 sessions of brachytherapy to reduce all these delays, patients looking for money, could actually be equivalent to the 3 sessions. So that is what we are exploring, and we'll have to wait for the final outcome.
Great. So thank you very much, Dr. Angela Waweru, Dr. Catherine Nyongesa, and my co-chair, Dr. Fiona. So we've come to the end of this session this afternoon, and we are now able to break for our lunches. I think you'll get your lunch coupons as you exit, and I want to thank you all for participating here this afternoon. Thank you very much.